I'm going to highlight just 4 key areas which I think have come to the fore in the last year or so in the management of device therapy. Firstly, we're going to just take a look at some of the latest technology in loop recorders, which I think many of you will be interested in. Secondly, we're going to talk about the new NICE guidelines for ICD implantation, which came about last year and replaced the ones from 2006. A lot of people are not aware of them, but they are very, very important, I think, and it's changed quite significantly the way in which we're actually offering people ICDs for primary prevention. Thirdly, perhaps a bit more specialized, but again, there's been a new risk stratification algorithm from the European Society on patients with hypertrophic cardiomyopathy, which I'm sure you know is the commonest cardiomyopathy that we see in clinical practice, and I'm sure many of you have got patients with them. But the new algorithm actually has been structured in a different way, is extremely user-friendly, so I think it's very important that we're all aware of it. And then finally, something that we've been doing quite a lot more of at Barts in the last 18 months is putting in leads into the left ventricle in patients where we can't actually implant the leads through the usual route of the coronary sinus for biventricular devices. So these are just 4 areas. There are many other areas, of course, in device therapy that have come to the fore in the last year, but unfortunately, I think in 30 minutes, I'm probably not going to have time to go through everything, but happy to chat about any questions that you have afterwards. So let's start with loop recorders. I'm sure you're all familiar with loop recorders. You use them to diagnose infrequent or unpredictable symptoms in patients, notably palpitations, dizzy spells, more worryingly blackouts. But the important thing about any kind of ECG monitoring, be it a 24-hour Holter at one end of the spectrum to a loop recorder at the other, you've got to choose the appropriate test. And one of the things that we as electrophysiologists see time and time again when we get patients referred is that everyone's had a 24-hour Holter. It's almost become a default test. And in the vast majority of these patients, it's completely unhelpful. So the only time to order a 24-hour Holter, and I'll say this right at the beginning, is if you've got patients whose symptoms, they're getting several episodes of symptoms within a 24-hour period. A 24-hour Holter may very well give you the answer. Or alternatively, if you've got a patient with atrial fibrillation who you're managing with rate control and you want to see what that rate control is like, then a 24-hour Holter is helpful. Okay? For everybody else, you should not be doing 24-hour Holters. And instead, what you need to do is choose the appropriate test. And that could be a 24-hour Holter, a 48-hour Holter, a 7-day Holter, even a 14-day monitor, which is what we have increasingly these days, and then past that, a loop recorder. Okay? And if you choose the appropriate test, it's a lot more cost-effective, and the strike rate in terms of your ability to make a diagnosis is far, far greater. So with loop recorders, you know, the frequency really needs to be less than once every 2 weeks. Okay? In which case you would think about fitting an individual with a loop recorder. Another area where loop recorders have been shown to be particularly helpful is in patients who've had cryptogenic stroke, an embolic stroke. They go through the usual gamut of investigations in stroke unit, one of which is a 24-hour Holter. And a lot of these patients, nobody really knows why they've had a stroke. A significant proportion of those individuals have actually got atrial fibrillation that's just never been diagnosed. And loop recorders, and there's some very good studies in the literature, have been very effective at picking this sort of thing up. Now, the device that I'm going to talk about specifically is something called the Reveal Link, which you can see there mentioned at the top, which is the next iteration of the standard Reveal devices that we've put in for many, many years. So, as you can see there from the picture, it's the smallest loop recorder that is currently available on the market, and it's 87% smaller than its cousin, which is the one on the left, the Reveal XC, which is the device that we've always put in. It's about a third of the size of a AAA battery, so it's very, very small. It's got good longevity. It can stain for up to 3 years. It's got a far better AF detection algorithm. As with the previous devices, they are compatible with MRIs. But one thing that's particularly nice is that it's got a wireless Carelink, as it's called, home monitoring system. And you get that for free within the cost of the device itself. And so this is a wireless unit, which you can see there at the bottom, which essentially allows a patient, if they've activated the device manually with their magnet, to then essentially call up the hospital and actually send in a transmission through that wireless unit from their home. And the electrograms from the device will come through to us. we can look at it and see if we've made a diagnosis or not. So it's become a lot more user-friendly. The other good thing about this particular device is that it all comes packaged in one box. Everything you need to actually put the device in is in one packet. Okay? So perhaps if we could go to the video there then, please. Let's just see. No, it's not going to work there. Right, so this is an implant video. It's from YouTube, as you will see. Just have a look at this, actually. So there, the two blue things you can see the device is actually loaded onto this sort of plastic introducer. It's got a little plunger. There, they're just using a usual scalpel to make an incision. In fact, the thing actually comes with its own scalpel. So a little nick, about a centimetre or less, all with a bit of local anaesthetic. In goes the introducer needle. There you go. You turn it around 180 degrees. In goes the plunger. You lift it up a little bit. In goes the device. And then you put a bit of glue on. That took about 50 seconds. Okay? No stitching involved if you don't want to. You either steri-strip that wound or you can use Dermabond glue.
Where's it going?
In the usual place, actually, on the chest wall here, 45 degrees down, roughly where the heart is on the left side. Okay? So that takes about 50 seconds to put in under local anaesthetic. Patients can go home within 30 minutes. All right? So that's much, much easier than the former devices where they would have to come to hospital. We would usually take them to the cath lab. It would take 15 minutes to do, but it was a minor surgical procedure. This is actually a lot easier. And the reason why I think this is particularly exciting is that I'm sure there are many of you in the audience right now thinking, maybe I could do that. Yes? I'm sure if you're used to doing a variety of implants or hormonal implants, it's the same thing. It's actually not that much bigger than a contraceptive implant or, you know, a hormonal implant. So I think those of you with an interest in cardiology, I think this is a very exciting development because there's no reason why this actually has to be done in hospital. It could be done in your surgeries if you've got the appropriate setup. You know, you need a sterile drape, a bit of skin prep, and a bit of lignocaine. And you actually just slot the thing in. The monitoring device you get for free with the device. Okay, you just set the programming up for the patient at home, and that's it. Okay, I think it gives you as GPs a lot more power to actually make the diagnosis rather than having to refer the patients up to the hospital. The reason why it's particularly exciting, I think, actually, is that there's a real opportunity here for a collaborative effort between us as cardiologists in the hospital and you as general practitioners, because, of course, putting it in is easy. It's the actual acquisition of the data and the analysis, which is a much bigger thing. But then, of course, most modern pacemakers and ICDs and biventricular devices have remote monitoring, you know, like Carelink set up with it. Okay, it's the same monitor that you would use to monitor a pacemaker or an ICD. So we are set up in hospital to acquire this sort of data. And there's a real opportunity for a collaborative effort between the hospital and the general practitioner to help you acquire and analyze the data and actually make the diagnosis in the patients. Okay? So I actually think this is going to be a big step forward, not just in diagnosing palpitations, query cause, but also in patients with strokes, you know, which we don't routinely put these devices in patients who've had strokes. But the evidence is actually quite good. If it's stroke, and we don't really know what if there's no obvious cause, if you stick a loop recorder into these patients, a substantial number of them will actually have AF. And of course, they will then need anticoagulating, et cetera, et cetera. And the most important thing is loop recorders are actually very, very cost effective in terms of your ability to make a diagnosis quickly. Okay, far, far cheaper actually in the long run to use a loop recorder than to do 24-hour halters on a lot of people. So I think, you know, of all the novel technologies that have come to the fore in the last 18 months, that is something that's actually very, very exciting. So moving on from there then, the new ICD guidelines from 2014. You'll probably all be familiar with the guidelines from 2006, whereby for ischemic heart disease you need an ejection fraction of less than 35%. You had to have had a heart attack more than a month before. And then there were a couple of other little caveats which were actually not very evidence-based that would then determine whether or not your patients got ICDs. These new guidelines are completely different. This is all available free online from NICE, and I would recommend that you all actually download this and probably laminate the table or have it on your computer screens in your surgery whenever you see patients with heart failure, because it pretty much tells you everything you need to know. There have been some very important changes. As you can see from the table here, you've essentially got along the top the NYHA class of the patient, and down here you've got how broad the QRS complex is. on their ECG. So, if we start at the top, if you've got a normal QRS complex, the ejection fraction is 35% or less, so 35 is good enough. And if you've got heart failure symptoms in class 1 to 3, they all get an ICD. That's easy. I don't think that's a major change from what we were doing previously. What has changed is patients with class 4 symptoms, okay? That an ICD or cardiac resynchronization pacing is not clinically indicated. Now, according to the old guidelines, if you had class 4 symptoms, you could still consider them for a dual chamber ICD for primary prevention. Okay, so that's been an important change. Moving on to the next category, so your QRS complex is now getting broader. So it's 120 to 149 milliseconds, but without left bundle branch block. Okay, again, class 1 to 3, you get an ICD. Not that different to what we were doing before. But if you're in class 4, you don't get an ICD, you get a biventricular pacemaker. And I'll come back to why those changes have happened. As the QRS gets broader still, okay, this time you've got left bundle branch block now. Okay, so 120 to 149. If you've got class 1 symptoms, you get an ICD. If you've got class 2 symptoms, you get a biventricular ICD. Okay, if you've got class 4 symptoms, you get a biventricular pacemaker, not an ICD. And if you've got class 3, well, there's clearly an overlap between these two categories. And so you could have either one, and one uses one's clinical judgment in those situations as to which device you give the patients. Big difference to the 2006 guidelines. And then finally, and this has been a big change as well, if your QRS is more than 150 milliseconds duration, regardless of whether you've got left bundle branch block or not, then if you've got class 1 symptoms, you immediately get a biventricular ICD. Not something that we were doing before. You would have to have class 3 or 4 symptoms before we would think about putting a biventricular ICD into anybody. Class 2, you get a biventricular ICD. Class 4, you get a biventricular pacemaker. And again, class 3, there is an overlap. So the big changes have been in this population of class 4 patients, where particularly if the QRS is prolonged, you no longer qualify for an ICD. You actually qualify for a biventricular pacemaker. Okay? And the reason for that is if you actually look at all the trials for ICD and in heart failure, you actually find that if your heart failure is so bad that you're in class 4, you know, being shocked by an ICD for ventricular fibrillation or ventricular tachycardia doesn't actually improve your prognosis much. Okay? Because most people are either probably going to die from the heart failure, pump failure, and the final sort of cardiac arrest rhythm usually in these patients is either pulseless electrical activity or asystole. In the old days, and this has been very well demonstrated in the research literature, if you actually look at patients who've got severe heart failure, who've had ICDs, and then they die, okay, if you then analyze their ICDs just before they died, if they'd had shocks from the device, you actually find that a lot of these patients do in fact get ventricular fibrillation or ventricular tachycardia, and the ICD does very well at actually terminating it. The problem is, if they've had multiple shocks, they then go into pulseless electrical activity or asystole because they've been shocked by the ICD. So they die anyway. Okay? So just because they've been shocked by the ICD and it's done very well at terminating the ventricular arrhythmia doesn't actually make them live any longer. That's been quite nicely shown from a lot of the papers that were written about this particular population of patients. And so I think it is quite right that if your heart failure is that bad, you're not really going to benefit from an ICD. But remember, just having biventricular pacing itself actually confers a prognostic benefit if you look at some of the trials. Okay? And then similarly, going down here, if your QRS duration is, 150 milliseconds is a very, very broad QRS. Okay? And whether you've got left bundle branch block or not, there is going to be a significant timing difference between the contraction of the two ventricles, what we call desynchrony. And so you're therefore much more likely to benefit from having biventricular pacing. And that's why patients in the bottom row, they all actually qualify for some form of biventricular pacing, either with a defibrillator or without. These guidelines are still not perfect, and inevitably, you know, one has to use one's clinical judgment in terms of deciding who gets what device. And you know, as Dr. Ranjan mentioned during the question and answer session, you've actually also got to look at the biological age of the patient as well, you know. If you've got patients with multiple comorbidities who perhaps do qualify automatically for an ICD, I think it's quite orthopedic to just go ahead and put an ICD into them. You've got to look at the patient and actually decide, you know, if they really are going to benefit in the long run from having the device put in. So these are guidelines at the end of the day. But I actually think this is a big improvement on the previous guidelines, and this table in particular is extremely user-friendly. So I would, recommend that you all used it in all of your patients from now on. So moving on from there then, I'm going to talk a little bit about sudden death risk in hypertrophic cardiomyopathy. It's a much smaller population of patients, but it's the commonest cardiomyopathy we see. And it's a very important diagnosis because a lot of these patients are young, otherwise don't have any other problems. And they can have sudden death, which is obviously very catastrophic for the individual concerned, but also for their families. And of course, any dependents that they have. So it's actually quite an important condition that we should all be aware of. Up until, again, 2014, the way we actually dealt with device therapy in hypertrophic cardiomyopathy was actually quite easy. If you'd survived a cardiac arrest, or if you'd actually had sustained VT, ventricular tachycardia, you would automatically get a device put in. I don't think that's actually contentious at all. That's secondary prevention. Everybody should get a device, and that hasn't actually changed in the new guidelines. What's changed is how we actually do primary prevention. How do we identify patients who've actually are at significantly increased risk of dropping dead in the coming years? And up until last year, there were 5 major criteria that we were using. So we were using syncope, unexplained syncope, non-sustained ventricular tachycardia, a family history of sudden death, an abnormal blood pressure response on an exercise stress test, and on imaging, either cardiac MRI or echo, a maximal left ventricular wall thickness of more than 30 millimeters. That's a pretty thick ventricle. Now, if you had 2 out of those 5, we would deem that individual to be at significantly increased risk, and they would automatically get ICDs. And we've been doing that for the better part of 10 years. There are a lot of young people out there in their 20s and 30s going around with ICDs. However, if you actually look at the prognosis of the majority of patients with hypertrophic cardiomyopathy, it's actually pretty good. The vast majority of people with this condition do not just drop dead. It's not like ischemic heart disease and poor left ventricular function. And so the guidelines clearly needed to be refined, because if you can avoid putting an ICD into a young patient, then that would be desirable. Because at the end of the day, if you stick a device into somebody, and I've stuck ICDs into people in their late teens, early 20s, well, then they've got a lifetime of device-related procedures ahead of them. They're very likely to have a complication and get very sick from that complication. So the emphasis is now trying to avoid sticking devices into people unless it's absolutely essential. And that's how some of these guidelines have come about. So I've actually taken this from the European Society of Guidelines as they stand at the moment. I apologize for the size of it, actually. It's actually quite small. The things I'd like to point out, first of all, are this page here actually shows you the risk calculator. Okay? That's the actual internet link for it. So if you click on that, this page will come up. And then all you've actually got to do is put in these numbers here, and it comes up with a 5-year risk of sudden death score for you automatically. Works very well. I've tried it. And if the risk is essentially 5% or greater, the patient gets a device. Okay, so now we're actually talking about 5-year risk and percentages. We're not just talking about 2 out of 5 risk factors, you automatically get a device. It's a little bit more sophisticated. In terms of the actual algorithm itself, again, so secondary prevention, no one's going to argue with that. If you've had a cardiac arrest or you've got sustained VT, you should have an ICD put in, regardless. But here, as you can see, the factors that we take into account have now changed. So age has now become an important factor. The family history is still there. Unexplained syncope is still there. The severity of the left ventricular outflow tract obstruction has now been included. The wall thickness measurement is still there. Left atrial diameter has come in. One of the common problems that the majority of people with hypertrophic cardiomyopathy get, probably by the time they're hitting their 40s and 50s, is atrial fibrillation. And they're actually at very high risk of actually having a stroke. And as a result, even if they don't have any other points on the CHA2DS2-VASc scoring system that you routinely use, if we see atrial fibrillation in somebody with hypertrophic cardiomyopathy, we automatically anticoagulate them indefinitely. Okay? And non-sustained VT is still there. Okay, so the numbers, the actual factors that you use to actually determine risk have actually changed slightly. And then you plug that data into your scoring system and you come up with a score. So again, if the 5-year risk is less than 4%, note the wording, ICD generally not indicated. Okay? So there are exceptions to all of this. Okay? At intermediate risk, you may consider it, and certainly if you've got a 5-year risk more than 6%, you should definitely have one. The reason why this has been worded in this way is, of course, none of these algorithms take cardiac MRI data into account. And the majority of patients these days with this condition have a cardiac MRI. Okay? And that's why this algorithm is going to change again when someone actually figures out how to incorporate cardiac MRI data. A lot of patients with hypertrophic cardiomyopathy have got a lot of diffuse scarring in their left ventricle. And there's very good correlation, if you look at the literature, between the extent of that scarring and your risk of actually having a cardiac arrest. Okay? And so patients down here, for example, who are at intermediate risk or even low risk, if they had a cardiac MRI and you found that there was actually quite a lot of diffuse scarring, well, then they may benefit from having an ICD. And that's going to have to be a clinical judgment. So that's why this thing has actually been worded in a very, I think perhaps a slightly non-committal way. It gives you a little bit of leeway in terms of deciding who you're going to put a device into or not. Okay? But it's very user-friendly and very easy. So finally then, transeptal endocardial left ventricular pacing. Now, this is something that we've been doing quite a lot of in the last 18 months at Barts. But essentially, these are for patients who meet the usual criteria, as we talked about earlier in the new NICE ICD guidelines from last year, for a biventricular device. But the traditional approach of actually getting a pacing lead to pace the left ventricle is for us to actually go via the coronary veins. Okay? So the coronary veins generally run alongside the coronary arteries, and they drain blood from different parts of the heart. So traditionally, we would use a lateral coronary vein, which will run alongside the coronary arteries going around the back of the heart, and the blood would drain into a structure called the coronary sinus, which runs around the mitral valve and empties blood back into the right atrium. Okay, so if we wanted to pace the left ventricle, we would stick a lead into the coronary sinus from the right atrium and around the back of the left ventricle inside the vein, and that would allow us to pace the two sides of the heart. That's the way we normally did it. With an endocardial lead, we're doing what we normally do with our pacing leads on the right side of the heart. We're actually screwing them to the inside of the left ventricle. And therefore, all patients who have this done need to be anticoagulated with warfarin indefinitely. So the majority of patients that we've done are patients who are already on warfarin because usually they've got atrial fibrillation or some other indication. But the case that I'm going to show you in a moment, the lady did not have an indication for warfarin. And she actually agreed to go on to lifelong warfarin so that we can actually do this for her. So, biventricular or cardiac resynchronization pacing, the aim essentially is to correct any significant conduction delays between the right and the left ventricle. Okay? That therefore improves the hemodynamics of the heart and produces symptomatic and prognostic benefits, but not in everybody. There is still quite a significant no responder population, whereby they meet the criteria for a biventricular device, but they don't actually feel any better afterwards. And we're still not that good at identifying which people will benefit and which people don't. The majority do, about 2/3, but up to 1/3 sometimes get no benefit at all. And as I said a moment ago, the standard approach really is to insert the lead via the coronary sinus into a lateral vein. Now, the problems with that approach are that you can only put the lead where the vein's going to take you. Okay? And often the vein is not suitable, or if someone's had a myocardial infarction, which is the commonest pathology we see, the lead might actually end up sitting in the middle of the bit that's been infarcted, and it simply won't work. Okay? The second thing is the leads move. They can displace quite easily, they can come back, and as a result, patients either have multiple procedures or we simply aren't able to give them cardiac resynchronization. And the third thing is a somewhat theoretical point, but the standard approach of biventricular pacing from the coronary veins is actually unphysiological. If you look at the physiological literature on cardiac activation, during a cardiac cycle, the ventricles are actually electrically activated from the endocardial surface to the epicardial surface, not the other way around. So the way we put biventricular devices in at the moment, we've got a vein sitting on the outside of the left ventricle in the coronary vein, so we're activating it from epicardial to endocardial. But that is purely a theoretical consideration. So, there is this novel approach, and what you can see from this diagram, it just helps you to understand exactly what I've been talking about. So just to recap, what we do at the moment classically in the technique is a wire will come down into the right atrium. The coronary sinus runs along that yellow line there, so it goes round a corner into the coronary sinus, around a corner again into a lateral vein to sit down here. Okay, technically quite difficult in a lot of patients, and the leads have to go around a couple of bends. This approach, the lead comes into the right atrium. We make a hole in the interatrial septum, which is called a transeptal puncture. It's a standard technique that we use during catheter ablation day in, day out. And we actually push the lead through into the left atrium, through the mitral valve, and onto the free wall of the left ventricle. We are not dependent on the anatomy of the vein. You can put that lead wherever you like. It's got a screw on the end of it. You just screw it into the free wall of the ventricle. Okay, so it's actually going through and taking a route like that. And so you can see it's actually sitting, in the left heart endocardially. And so therefore lifelong anticoagulation is very important. So this is an example. This lady, as you can see, has had previous cardiac surgery. She was only in her late 50s. And you can see she's had a biventricular ICD put in. She's got an atrial lead. She's got a shocking lead down here in the apex of the right ventricle. Okay? And this is her original left ventricular lead. It's going into the coronary sinus. And in fact, it was originally sitting around the back of the left ventricle here. And it came back on 2 occasions. So this was actually her third procedure. So you can see here now there is a tube coming down into the right atrium, and then it's going through the interatrial septum here. So it's now sitting in the left atrium. And here is this active pacing lead coming out into the left atrium, through the mitral valve, into the left ventricle, and it's been screwed into the free wall of the left ventricle. So her original left ventricular lead would have been going round like this and coming round and sitting about here. Okay? And then here the actual guiding sheath has been pulled back and split. So here you can see now she's got a transeptal left ventricular lead sitting there. And this lead we actually pulled out again at the end of the procedure. I saw this lady recently, 6 months after the procedure. And her heart failure symptoms have improved again. She had a quite dramatic response to the biventricular pacing. Every time these leads would displace, she would start getting significantly breathless. That has all settled down. Her exercise capacity is improved. And she's actually feeling in general a lot better. So what remains to be seen now is actually how she does. It's only 8 months down the line now in terms of how this lady's going to be in a couple of years down the time. It's still very early days. We don't know how these leads are going to behave 5, 10 years down the line. But I suspect increasingly as the technology improves, we may be doing this more and more for a lot of our heart failure patients. And we may find, because this is a much more physiological mode of pacing, that the outcomes in terms of not just the heart failure, but also their burden of ventricular arrhythmias may also be better. Thank you.